Good afternoon, ladies and gentlemen. My name is Paul Malloy. I am the CEO of ClearFlow, Inc., which is a California-based company, and we're very happy to be able to present with our U.S. partners, Gettinger Group, our symposium workshop this afternoon. So thank you for attending. The title, as you saw from the poster, is The Clinical and Economic Benefits of Maintaining Chest Tube Patency After Cardiothoracic Surgery. And we have a very well-respected and erudite panel of physicians, Dr. Gillinoff from Cleveland Clinic, Dr. Louis Perot from Montreal Heart, and Dr. Boyle, the founder of ClearFlow and a cardiothoracic surgeon in his own right, to present the recent research and findings on this subject matter. As you know, we live in interesting times in healthcare. There's a lot of change afoot, fundamental questions about how we're going to be able to pay for healthcare in the future in a country that's already spending 16% of GDP and yet has a lower life expectancy than countries spending half that much, higher infant mortalities, lower rates of vaccination. And so the question of what is worth it, to whom and why, comes up all the time. And we're discovering that the decision-making process, the parts of the care bundle in this country, in our healthcare system, are not fully integrated, that it's very difficult to make good decisions, and that a lot of the decisions made on the margins have a dramatic impact on the total cost of care. Yesterday we heard a very interesting talk from Medtronic, citing the work from Michael Porter, famous marketing professor now working at Harvard, who invented an equation saying more or less that value equals outcomes divided by cost. And if you think about that in terms of strategies for treatments, the usefulness of devices in a care bundle, then how we decide what is valuable is really the key question to be determined, both for hospitals as well as for companies and physicians. And our talks today really revolve around some of the effects of device technology in the ICU setting, but also used in the operating room to begin with, that can have a dramatic effect on outcomes and therefore on cost and therefore totally on value. So with that, I look forward to an interesting discussion. Please do prepare some questions for our panel, and I'll introduce Dr. Edward Boyle to hand off.
Thank you, Paul. So I'm going to kick things off and take you on a journey that starts with a chest tube and ends, like Paul talked about, how the function of that chest tube can impact not only complications but cost. And then after I get things started, we've got Dr. Gillinoff and Dr. Perot, who will be contributing to that as well. So we all know that every patient after heart surgery requires a chest tube. You basically can't work inside the chest operatively without draining any blood or fluid that results. And we know that they all require it, but the big question that we came up with was, do they always work? Because my impression was that sometimes we would take patients to the operating room after an operation because there was fluid around their heart or fluid around their lung or blood or a take back, and I'd look at the chest tubes and they'd be clogged. And I'd think to myself, listen, if a patient's still bleeding, that chest tube better be open. And if that chest tube's not open and they're still bleeding, it's gonna have to remain somewhere, and it's gonna be around the heart or the lungs, and that can impact their outcomes. So when we first started talking to folks about this, people would say, yeah, that happens, but I'm not so sure how often that happens. And so I teamed up with Dr. Gillinoff and his team at the Cleveland Clinic, and they did a study, a prospective observational study working with the ICU nurses at the Cleveland Clinic, and they were able to observe that 36% of chest tubes have evidence of clogging, complete clogging, in the first 24 hours after heart surgery. And that was a bit of a surprise because we knew, we'd actually done a published survey talking to people about clogging, and everybody said, yeah, I see it, I just don't know how often it happens. Well, this is the first time we were able to quantify that it happened, in almost 4 out of 10 patients. And what was interesting is mostly the clogging was on the inside. The nurses might be able to pinch or squeeze or even strip the chest tubes and get it all clear up to the skin level. But where that clogging was on the inside, the business end of the chest tube where the drainage holes were, and it often went unnoticed by the care providers at the bedside. So we started thinking, well, how can we study the clinical result of this? Yes, chest tube clogging is a chest tube problem. It's not a patient problem. What's the patient problem? So we said, well, maybe it's a take back for bleeding, or maybe it's a bloody effusion, or maybe it's a bloody fluid around the lung or heart. And so we ended up putting together a working group to study this, and we came up with the term retained blood syndrome to kind of encompass at a composite level several different things that can happen if your chest tube clogs. And then again, the next question was, well then, how often does that happen? And again, how does chest tube clogging result in retained blood? So this is kind of a schematic of that. At the top is an open chest tube that's draining great. So what happens, it sits in that mediastinal space or the pleural space, and it sucks it down and the blood comes out. But if that tube occludes, blood is going to build up around that chest tube. And then even if you reopen the chest tube later with a suction catheter, you've still got this big clot of blood that can't make it to the chest tube. And so keeping that chest tube open, we hypothesized, was going to be the way to get all that blood out of there so it doesn't have a time to accumulate and cause problems. And then when we looked at retained blood syndrome, we said, well, this is something that might happen acutely in the first few hours, and that's what everybody thinks about. The take back for bleeding is very dramatic, everyone notices. But what about the subacute? The patient that goes home and ends up with a chest half full of blood, or the patient that has blood around their heart, and they may not know it, but they're just not feeling good and recovering as quickly as you would like. And then obviously we've got famous cases like Bill Clinton, who after his operation ultimately had to go back for a decortication because he had a big fibrous peel around his lung, and that happens as well. So this is something that might manifest acutely and get noticed, subacutely, or chronically. And trying to pull all that together was the intent behind this term retained blood syndrome. And the nice thing about it is it's easy to measure what a hospital's rate, because if you define it as an intervention to go back in and remove blood, blood clot, or bloody fluid after a heart operation, then there's codes for that. There's ICD-9, ICD-10, CPT codes. And we started going to hospitals and saying, hey, would you look at these codes? And pretty consistently, it was kind of like 1 out of 5 to 1 out of 6 patients, or anywhere between 15 and 20%. And then we looked at the national data, a sample of over 300,000 patients in the United States. Again, we could see it. So this was something that we recognized. This happens a lot more than we thought. And then we started asking, okay, what are the outcomes for the patients that end up with retained blood? And this is a paper that was in the August edition this last month of the Journal of Thoracic and Cardiovascular Surgery. And this was from a cohort of 7,000 patients, of which 20% had retained blood and the other did not. And that group, which I think this was presented at this meeting last year by Dr. Balzer, showed that mortality was up 106%, significantly longer ICU times. And we hear from a lot of programs that sometimes the ICU becomes a bottleneck, and you have to slow down your OR until you can get some people out of the ICU. So longer ICU times, higher rates of post-op Afib. And we also saw that in the chest tube clogging study from the Cleveland Clinic. Higher rate of chest tube of Afib with the chest tube clogging or with the retained blood. More kidney injury, increased infection. And then we did another study where we looked at how much this cost. And in the United States, when a patient has retained blood, it increases their cost of care by $28,000, which is significant. And so, and it was very similar in Europe as well. So if you take, 100 patients and 17 of them get this, that's almost $500,000. If you're doing 1,000 cases a year, that's a $5 million a year problem. So now we've kind of learned that here you have this problem, chest tube clogging, which can cause these recognizable and measurable clinical events like a tamponade, a hemothorax, a bloody effusion. And then after that happens, you layer on these secondary complications like kidney issue, post-op Afib, stroke, delirium, mortality, infection. And ultimately, that ripples out to consequences at the cost level and also at the throughput level for the ICUs and the hospitals that are trying to get people in and out in an efficient way. So here's this little problem. Chest tube clogging has this ripple effect that impacts the bottom line at the hospital and also all of your jobs just trying to take care of these patients every week. And in the last month's Journal of Thoracic and Cardiovascular Surgery, some surgeons from Europe were asked to do a editorial on this subject. And they wrote that, surgeons really should kind of keep in mind that, especially when we're starting to compare things like Afib surgery versus Afib ablation, or mitral valve percutaneous versus mitral valve open or robotic, that even these little complications like an effusion, like an Afib, like a take-back, can really influence whether we even get to do these operations in the future. And so even what we consider to be sort of mild nuisances actually can have a big impact that goes way beyond just a clogged chest tube. Now, when I got this company started, I ended up teaming up with Dr. Gilinoff very early, and he introduced me to Dr. Perot and some of the others, and we've had a working group working on this, and we've been very lucky to get some excellent studies going at some of the top places in the world. And Dr. Gilinoff's going to pick it up from here and kind of talk about the product, Pluriflow, that was developed to address this problem and some of the outcomes from using that in terms of reducing complications. And then, as I mentioned, we've seen some really interesting stuff that by preventing chest tube clogging, you might be able to reduce postoperative atrial fibrillation, something that all of you see every day. And Dr. Perot is going to talk about some of the work he and his colleagues have done on postoperative atrial fibrillation, both in the lab and clinically. So I'll hand it over to Dr. Gilinoff next. Thank you.
Thanks. My name is Marc Gilinoff. I'm a heart surgeon at the Cleveland Clinic. I got interested in this topic on a summer night in 1999. A friend of mine who had trained with me, actually he was still training at Johns Hopkins, called me up and said, "Hey man, what are you doing?" And I said, "I'm sitting in the ICU at the Cleveland Clinic. I'm in G54, which is the name of the unit, and I'm trying to take care of this patient I operated on this morning." And he said, "You're an attending now. You should be home. It's summer. It's July. You know, you should have a Heineken and you should be grilling some steaks because I'm still a resident. That's my job." I said, "Well, it's not quite like that here." He said, "So what's the problem? Why are you're a newly minted attending. You should be having fun. Why are you in the hospital? Why are you in the ICU in the middle of the night or soon to be middle of the night?" And I said, "I can't figure out if this guy is bleeding. This guy operated on this morning, I don't know if he's bleeding. He was bleeding, or let's say his chest tubes were draining 200, 300 an hour for about 4 hours. Then they stopped. They stopped draining. And initially I thought, that's really good. He stopped bleeding. We gave him platelets, we gave him FFP, whatever was wrong is not wrong anymore. Then his blood pressure started to get a little soft, and we started to give him some fluid. And then someone said, let's get an echo, which the usual thing with an echo at this point is it's indeterminate. Echo is not the way to deduce tamponade or not. So I said, I'm sitting here trying to figure out, is the guy bleeding? Is he hypotensive because he's tamponaded? Are his tubes clotted? And he said, wow, 9 years of training, 4 years of college, 4 years of medical school, and you can't figure out if a hose inside a person is open or not. We are pathetic. And he was right at the time. You know, a lot of my colleagues and like surgeons everywhere would say, oh yeah, I don't have that complication. Well, we all actually do have that complication, and that was the impetus to say this cannot be that big a problem. I mean, they're hollow tubes. Let's turn it into a system that stays open. So here's what it looks like. This is an active clearance technology. This is not a chest tube. It is a system that makes a person drain. It is a chest tube with extra things that make it drain, something to floss it out. And we did realize what I did with this patient that night was I went up to the bedside, I laid down some blue chocks. Have you seen anyone do this? I sprayed betadine all over the place, made a huge mess. Then I put on some gloves, pretending that now it was all sterile. I broke the seal of the chest tube. I took a several $100 Fogarty catheter. I ran it up and down thinking, gosh, I hope I don't hit a bypass graft or something, but I don't know how long the tubes are. But let's cross our fingers and hope it goes all right. I pulled out some clot, and I thought, I wonder if that's all, so I did it for a few more minutes. And then the patient did okay. Then he didn't even get an infection from my violating principles of sterility. And we say, wow, the solution we've got today to a problem that we haven't solved, not so good. Let's just solve the problem. So here is the solution. You see there is a chest tube in the person, but attached to that, between the chest tube and the drainage canister, is the system that keeps it open. And here's what the system looks like. You've got inside the tube on the bottom a guide wire think of it as a flossing element. It's almost like it's a Roto-Rooter. I mean, we could have stolen this from the Roto-Rooter company, but fortunately they didn't have the patent, and we do. And you just run this Roto-Rooter-like thing up and down the tube. It's got a little pigtail on it, and it just morcellates clot so that it gets sucked out very easily. Let me go back one sec. I want to show this. The thing that is sort of magical about it is the way we move this pigtail up and down through the tube is by a magnet. At the end of this pigtail catheter is a magnet that we can run it up the tube, run it down, and it flosses the tube out. It lets the pigtail and the guide wire go in and out, and it's of such a length that you can't put it past the exit of the tube, meaning you can't encounter the heart or a graft or a valve or anything like that. It stays inside the tube and flosses it out, and this means I don't have to break sterility, or you don't have to break sterility to do it. It's all integrated. And it works. You just clear the tube. When you try to milk the tube or tap the tube or do something at the skin edge the usual way, you might be able to clear the part of the tube you can see, but what Ed just showed you is most of the cut is actually on the inside. It's the part you can see. So this gives me the assurance that the tube is clear, it's doing its job. So does it work? I mean, it's a pretty obvious concept. Of course it works. We did it in animals. It worked great. But there aren't a lot of pigs who need heart surgery. If there are, we've got a solution for them. But there are a lot of people who need heart surgery. So for standard heart surgery, this study that you've heard about a little bit looked at people having bypass surgery, valve surgery, bypass plus valve surgery. And the center looked at their baseline data using standard chest tubes, and then looked at 256 consecutive patients treated with the chest drainage system from Pluriflow. So the Pluriflow system that's designed to keep the tubes patent. And here you see what happened. In phase 0, which is in the standard treatment, versus phase 2, which is when the integrated active chest drainage system was instituted, you see in the red decrease in interventions for retained blood syndrome, RBS retained blood syndrome. Basically, what does that mean? Decrease in interventions to get blood out of the chest, like draining pleural effusions, pericardial effusions, reoperation for bleeding. That went down 43%. And interestingly, post-op AFib was less in people with active chest tube technology or active clearance. This was initially a little bit surprising. Like, why would post-op AFib go down? And I was talking with Ralph Damiano about this, and I said, we find that when we have better drainage of blood from the pericardial space, we have less post-op AFib by quite a bit. It's a big noticeable reduction, statistically significant in everything. And he said, well, of course, that's obvious. One of the models we use in the lab is we take animals, put blood in the pericardial space, close it up, and they get AFib because blood is inflammatory. And if you leave blood on the heart, you're more likely to get AFib. You drain the blood, you're less likely to get AFib. And they said, how come you didn't know this? I said, I don't know, but I'm glad that you could explain it, because now we do know it. So I can tell you that's from Ralph Damiano, who's smarter than I am. If we look at patients, that was in all comers, regular heart surgery, and it worked, it was great. What about the people who you know are going to bleed? Ventricular assist device patients. These patients, they're almost all redos, they're anticoagulated. These guys are going to bleed. And if you look at two different devices, two different types of VAD or ventricular assist device, they tend to have most of their bleeding the first 3 days. And if you look at the axis, the y-axis, it's a lot of bleeding. You know, we're talking a liter plus. And the question was, what do we get in these patients if we have active clearance technology? And here's the answer. If we look at people having standard drainage versus active drainage with Pluriflow, we have a substantial reduction in interventions for RBS, or retained blood syndrome, 39% reduction, fewer re-expirations for bleeding, and less need for delayed sternal closure. These redo patients getting ventricular assist devices, they often bleed so much you have to leave the chest open. But if you know you can drain the blood, you can close the chest, which is a huge benefit because infection is one of the huge life-threatening enemies of VAD placement, and this lets you close the chest. If you do an analysis, that was raw data. If you then adjust for confounding factors and match the patients. You get the same thing. Active clearance technology reduces reoperations for bleeding, lets you close the chest earlier, and also avoids the need to place a new chest tube later on. Oftentimes, if you don't have good drainage initially, you have to place a new chest tube later. If you use PluriFlow initially, you're good to go. No new chest tubes. So I showed you two different scenarios with data. Regular patients, good results. Very complex patients who are going to bleed, also good results. That raises the question, which we're often asked is, so when should I use this? Should I just use it if I know I'm going to have bleeding, or should I use it in everyone? And a reasonable analogy is this. We wear a seatbelt all the time because we want to be ready just in case something bad happens. Do you want to be ready and be protected? Most importantly, do you want to be protected all the time, or do you want to wait for a fire and make sure you've got a fire extinguisher near you? Meaning, do you want to wait for the problem, wait for the disaster, and then try to recover? And of course, the seatbelt analogy works. You want to be ready, you want to be prepared, you want to avoid the problem. Don't let a fire start. Second question that comes up after when is, what about the money? Medical devices, medical care, you've heard, big part of our GDP. This costs money, but actually this saves money. This is a small investment to save a lot of money because the complication caused by retained blood, whether it's draining of pleural effusion, pericardiocentesis, back to the OR, reoperation for bleeding. Bill Clinton with his decortication, which I understand was, one of my friends did that operation. He said it was a miserable, terrible operation. The only thing good for him was he wasn't the guy having it, who was Bill Clinton. So these things are not only personally costing to the patient, they cost a lot of money, and preventing them saves money. So if you look to your left, if you're in a hospital that does 1,200 cases per year, you'd expect about 17%, 200 of those 1,200 people, 200 patients, are going to require some kind of drainage procedure for retained blood. And that's going to be very expensive, millions of dollars. If you had reduced the need for these procedures by active clearance technology, if you had put in the right chest drainage system, the best chest drainage system at the beginning, you would prevent about 42% of these, and you would actually save millions of dollars. So we're judged really in medicine by two things: how the patients do and how much money do we either spend or save. This checks out just right on both ends. Patients do better, and we save a lot of money by avoiding complications. And increasingly now, across the map, this is a map of the US, a little faded, but more and more centers are saying, yeah, this makes a lot of sense. Better outcomes, less spending, that's something we all like. This is not just a single person doing it, though. I mean, I place the chest tube in the OR with the PAs in the OR, but then the nurses in the ICU are the ones who are making sure they work, and they actually like doing that a whole lot more. Just run it up, run it back, push the magnet in, clean the tube, pull it back, good to go. They like that a lot more than trying to page the resident on call and find some guy who doesn't want to come to clear the chest tube. So way better that way, but it is the whole team, and it makes sense for everyone. And it's going to become increasingly important as we're under the threat of new payment systems. And basically what is going to happen, starting with the data from the coming year, programs that have fewer complications will be economically rewarded, and they will be rewarded by taking money from programs that have more complications. Programs that have more pleural effusions, pericardial effusions, reoperations for bleeding, decortications for fibrothorax, they're all going to be penalized, and that money will be given to the programs that had fewer complications. And it's going to increase year over year with the data being collected this coming year. So that's further impetus. If it weren't enough to say I want to do the best thing for my patient, it's going to be the best thing for the whole program, and it's going to keep us solvent to do it right. So we all have choices. Who should get this? All versus selective? I use it in all. Because if I were the one having surgery, on a personal level, if it were me, I want all the blood drained out of my chest. I don't want a complication. Active chest drainage, it just works better. When should you do it? We tend to leave the tubes in for a day, If somebody continues to drain, even if it's that clear fluid that you might see post-op day 1 or 2, if they're draining 50 cc's an hour, I'm going to leave it in another day because that will prevent me having to sit them up, do an ultrasound, and put a needle in their back to drain the pleural fluid, which no one likes. Why do it? It improves the quality and saves money. And how? I mean, we do it every day. On Monday morning when I'm in the OR, I will be placing these tubes because it's going to make my patients do better. It's going to prevent complications. And I'm particularly enthusiastic about it reducing the incidence of post-op AFib because that is such a nuisance. And anytime I can spare the patient and me and my team from post-op AFib, that's a good thing. Thank you.
Excellent. Thank you very much, Mark. That was a great presentation and I think very helpful. Next, Dr. Louis Perreault, who's a heart surgeon at Montreal, at the Montreal Heart Institute, is going to talk about the potential to reduce postoperative atrial fibrillation by reducing retained blood. And Louis is one of the very first surgeons in the world ever to use this technology. It's been used on almost 25,000 patients now. And so he's had a look at this from the very beginning to where it is now. And I think you guys will enjoy seeing what he has to say. Thanks, Louis.
Well, good afternoon, ladies and gentlemen. It's a pleasure to be here. It's actually my first time at this meeting, and I'll make sure down the road that I bring my team over. And I'd like to thank Dr. Katz for putting everything together. I think the team approach is obviously the only way to go. So we've been playing around or toying around with this device for a little while. This is a picture actually on the left of the first patient that was done in January 2011. And this was part of the initial clinical experience where we actually did a report. We had a survey of the surgeons, the OR nurses, and the ICU nurses to see whether they would like the device and if they saw any problems with it. And obviously it was very positive. You can read about it. It was published in Innovations. So we've published a few case reports, and now we're moving on to bigger papers. I have actually published a case report of a tamponade being relieved after milking and stripping with a lot of difficulties. And this is a case report that just came out in 2016 in the Annals, where we had the active clearance tube in, and we have on the left a patient that had a small effusion close to the right atria. And by actuating the system a little bit more vigorously than usual, we managed to pop out the clot and spare a take back, and I could go on with my evening. So post-op AFib, you all know, remains a big problem. 30 to 50% of patients will develop it. We say about 25% for CABG alone, but if you do a double valve with aortic stuff, it's probably closer to 50%. It obviously has an incidence on stroke and death, length of stay and cost, we've seen it. And obviously, not everybody has the same trigger, and perhaps that we won't ever be able to bring it down to zero, but definitely there is an individual susceptibility. Retained blood, as you've seen, and I'll try to explain, is an important, a powerful trigger for new onset post-op AFib. And it's oddly one of the most common complications of cardiac surgery, and currently there are no reliable preventative measures to get rid of it. So there's a history of failures. Most of you, depending how old you are, have seen these come and go. The pharmacological approach to preventing AFib. At our center, we've used sotalol in the past, amiodarone, N-acetylcysteine. None have been successful. 2 have been. These are systemic steroids and posterior pericardiotomy, but none of them, I believe, are used on a regular basis in North America. Post-op AFib, I mean, a persistent problem. If you pull out this paper looking at 72 studies, more than 55,000 patients going back all the way to 1975, you can see that nothing has lowered the incidence of post-op AFib. And in fact, if we think that our patients are older with more comorbidity, the incidence actually may be going up. What's interesting, if you look at the time course of development of post-op AFib, it actually follows the peak in inflammation. You can see on the bottom line, the dotted line is AFib after non-cardiac surgery. Some susceptible patients will develop. But if you look at the peak of AFib, which is around day 2 or 3, this parallels the rise in CRP in the plasma of these patients. So basically, post-op AFib definitely has an inflammatory component.
Pardon me, I just want to, first of all, thank you for being here and presenting this to us because it's important information and appreciate the company's support in helping our meeting. I know it's great support for the meeting. But, you know, I have a special feeling for this situation because over time, from time to time, new innovative technology occurs, which really can make a difference. And when I understood what this technology meant, and having stripped chest tubes in the past, and having, you know, gone through the whole thing with Fogarty catheters and the whole thing, and understanding the issue of retained blood and when is the patient hypnotic and the effects on multiple areas, when I became aware of this technology, I thought this is truly innovative, and this is a unique system. So I just wanted to say that to have them here at this meeting and to talk about it, I think is very important. As you know, it's very difficult to go into a hospital these days with the Sunshine Act and people to talk about this. But it's very important information, and I think as we go forward as a specialty, I think it'll become appreciated. This is unique technology. So I just wanted to thank you. I didn't mean to interrupt, but on the other hand, I want to tell you, I think this is really important. Thank you.
Well, thank you so much for your comments, and we'll try to prove you right. If you just look at two case figures here, we know that not all patients are going to get AFib. First example on the bottom, you have a patient that has the only risk factors may be hypertension. They go through CBP run. Obviously, you know, there'll be a little bit of inflammation, but for some reason, there's not enough for them to have AFib. In another patient, and that I would say is most of our patients nowadays, they have multiple risk factors, diabetes, hypertension, mitral regurg, and they go through the same CBP run, maybe longer, and inflammation occurs, and post-op day 2 or 3, they do develop it. So it is something that is triggered individually depending on the susceptibility. Now, this is a picture that's interesting. You can see here on the left side that there is a collection of blood. There is a chest tube squeezed to the left that is definitely not a standard chest tube, definitely not doing its job. And you can actually correlate the amount of blood that is retained in the pericardium with the amount of oxidative stress within the pericardial cavity. This is work from Mel B. in St. Louis, who actually documented that if you look at post-op myoglobin or in post-op CKMB troponins, they're elevated in patients that do have retained blood. And this is by comparing the level of these enzymes or these compounds in the pericardial fluid versus the plasma. So how does it work? Chest tube clogging leads to retained blood, and the retained blood will undergo hemolysis. There's free hemoglobin that will be released, and this will oxidize and attract neutrophils and produce radical oxygen species. This will cause lipid peroxidation, and this may cause atrial damage or irritation, which may trigger post-op AFib. And this is pretty well demonstrated, and this is why less retained blood most likely equals less post-op AFib. In Montreal, at the Montreal Heart in 2014, we did a study which the design was pretty easy. We asked the hospital, we're in a single-payer system, how many can we buy? So we actually were allowed to buy 150, and we had 10 chest tubes as a bonus if we did. So we started out with 160. One surgeon didn't get the program too well, so we had 158 patients in a row that were done. Once we were done, money out, we went back to our standard drainage, and then we studied 186 standard drainage patients, and 44 of them were excluded, obviously, because they had a history of atrial fibrillation. So we propensity matched them, and you can see that even though we did not have a statistically significant decrease in RBS, that the decrease in post-op AFib was spectacular with a relative risk reduction of 44% with an odds ratio of 0.46, and this translated into a one-day reduction in length of stay. So our baseline went from 36% to 20%. You want this here now?
Yeah.
I'll save it for the end.
Yeah.
So Considering we did not have a significant effect on RBS and we had a spectacular effect on post-op AFib, we decided to put together a prospective randomized trial that's led by one of my associates, Philippe Demers, who does a lot of valvular surgery and aortic stuff, and we put together this study, which is ongoing. Basically, our plan is to enroll consecutive patients, and basically the test arm is one pleural flow in the anterior mediastinum with other standard chest tubes in the pleura, etc., versus the control group, which is standard chest tubes at the discretion of the surgeon. This will be analyzed as an intent to treat, and we started with a baseline of about 25%. As I said, it's probably more around 30% depending on the mix of cases. So we calculated to get an 80% power to detect a significant difference. We needed 508 patients in each group, and we do plan an interim analysis after 300 cases, which is coming up. So basically, the inclusion criteria were any patients that were undergoing CABG, valve surgery, a combination of both. We excluded patients that were undergoing deep hypothermic circulatory arrest, and the patients had to be in sinus rhythm for the last 30 days before the index surgery. That's a given. In the exclusion criteria, we excluded, again, circ arrest and VADS, transplant, endocarditis, and different conditions. So the primary performance endpoint, this is a matter of debate, was the rate of any new onset post-op AFib as defined by a period of 60 minutes consecutive that was objectified by telemetry or EKG at any time between the index surgery and discharge. And this is based on the Affirm trial, and also this was the definition that was used in the Cardiothoracic Surgery Network paper on rate versus rhythm control that Marc Gilnoff and associates published in the New England a little while back. So to date, we've enrolled 200, I think as of 2 days ago, 253 patients, so we're close to the halfway mark, and we're looking forward to the interim analysis to see the effect we have. And actually, we're also doing sub-studies within this, especially looking at laboratory and pericardial fluid difference between the cases that did get ACT versus standard drainage, trying to repeat in collaboration with Dr. Melby's group some of their findings, and also looking at clinical investigations, mainly imaging, to see how much fluid or clots are retained in a post-op patient, either undergoing standard drainage versus the active clearance technology. And I'll go back to this. So if you look at the level of evidence, usually right now, if you think that we have two retrospective studies that are non-conflicting, this is the Nuremberg data and the Montreal data that show a reduction in post-op AFib. And if you consider that the level of risk is basically nil, considering all patients will need a chest tube and the benefits may be great, I think right now this device is class 1, level B evidence, and we believe that with the further studies we can bring it up to class 1, level A status. Thank you very much for your attention, and I'll answer any questions. Thank you.